So continuing with the brain images and the descriptions, on the left is the coronal graphic, and it shows the overgrowth of the left cerebral hemisphere. Note the shift of the midline structures, excess of white matter, thick flattened dysmorphic gyri, and abnormal ipsilateral anterior horn. The right image is the axial non-contrast CT scan in a 4-year-old female with intractable seizures, and it shows the enlarged right hemisphere, hemicranium, with enlarged white matter in the corona radiata, and ipsilateral corpus callosum, as well as the fornix. The forx is displaced across the midline. On the left is the axial T2 weighted MRI in the same patient, and it shows the enlarged hemisphere with hyperintense white matter, enlarged deformed right ventricle, and thickened dysplastic cortex. On the right is the coronal T2 weighted MRI, and it shows the right hemisphere is enlarged with the forx displaced across the midline. The ipsilateral frontal horn is deformed and pointed. The findings are those of classic HMEG. So this was a classic case of hemimegalencephaly. On the left is the coronal ultrasound image in a newborn with seizures, and it shows an enlarged right hemisphere with hyperechoic white matter and an abnormally pointed right frontal horn. The interhemispheric fissure is displaced across the midline. The right is the axial non-enhanced CT scan in the same patient, and it shows the grossly enlarged right hemicranium with abnormally hyperdense white matter in the frontal and anterior parietal lobes. Left image is the axial T1 weighted MRI in the same patient, and it shows the enlarged right hemisphere with marked displacement of the forx and interhemispheric fissure to the left. The ipsilateral frontal horn is pointed and the white matter is hypointense. The right image is the T2 weighted MRI in the same patient, and it shows that the white matter is expanded and hyperintense compared to the normal left side. The overlying cortex appears dysplastic and the gray-white matter junction is indistinct. Left is the axial inversion recovery sequence of the MRI, and it shows that the cortex of the entire hemisphere is abnormal. The frontal and temporal cortex is polymicrogyric, while the parietal and occipital cortex is thickened and flattened. On the right is the coronal T2 weighted MRI in the same patient, and it emphasizes the size difference between the right and left hemispheres, in this case of classic hemimegalencephaly. So let's start with the imaging descriptions of neurofibromatosis cases. So the left is the axial graphic, and it shows the enlarged right middle cranial fossa, dysplastic sphenoid wing, and a large orbital periorbital plexiform neurofibroma. Note the exophthalmos and the boophthαλmos of the involved globe. Right is the 3D shaded surface display of a patient with neurofibromatosis type 1, and it shows the enlarged right orbit with sphenoid wing hypoplasia, markedly enlarged superior orbital fissure is also noted. Left is the axial T2 fat suppressed MRI in an 18-month-old child, shows an extensive plexiform neurofibroma, which is infiltrating the scalp orbit and extending into the cavernous sinus through the superior orbital fissure. Note the bag of worms appearance. Right is the T1 contrast enhanced FS scan in the same patient, and it shows the plexiform neurofibroma, which is enhancing really strongly and mildly heterogeneously. Left is the axial T2 weighted MRI in a 7-year-old boy with the neurofibromatosis 1, and it shows multiple ill-defined hyperintense foci in both cerebral peduncles. The right image is the more cephalate image of the T2 weighted MRI in the same patient, and it shows the hyperintense foci in both globi pallidi, as well as patchy hyperintensities in both thalami. 6 years later, all the fosses had completely disappeared. Left is the T2 weighted MRI in a 13-year-old boy with NF1, that is neurofibromatosis 1, and it shows a single hyperintense focus in the left globus pallidus. The right image is of the same patient, but 6 years later, and now the T2 weighted MRI sequence. This is the T2 weighted MRI sequence, and it is normal. That is, the focus of abnormal signal intensity has completely disappeared. Left is the axial T1 contrast enhanced fat suppressed MRI sequence in a patient with neurofibromatosis 1, and it shows an enhancing lesion in the pons as well as enlarged enhancing optic nerves / chiasm. Right is the axial MR perfusion sequence, and it shows the increased right cerebral blood volume in the pons. That is, RCBV is increased in the pons. The optic nerves and chiasm show no increased CBV. Biopsy of the pontine lesion showed pilocytic astrocytoma, that is WHO grade 1 tumor, with no evidence for malignant degeneration. These pilocytic astrocytomas are quite vascular neoplasms, and they often exhibit a malignant-like spectrum on MRS, so don't be confused or don't be fooled with it. So coming towards the neurofibromatosis type 2 cases, so left is the axial graphic, and it shows the bilateral cerebellopontine angle schwannomas, which are pathognomonic of neurofibromatosis type 2. The tumor on the right is large, and several small schwannomas are also seen on the left vestibulocochlear nerves. The right image is the axial T1 contrast-enhanced MRI in a patient with typical NF2, and it shows bilateral vestibular schwannomas and a right cavernous sinus meningioma. On the left is the axial T2-weighted MRI in a 14-year-old male with left sensory neural hearing loss, and it shows a mass in the left internal auditory canal and another lesion in the right cavernous sinus. Note the small nodules along the right vestibular nerve. The right image is the T1 contrast-enhanced fat-suppressed MRI sequence in the same patient, and it shows the left internal auditory canal mass, which is enhancing, as does the right cavernous sinus lesion. In addition to enhancing nodules are seen along the cisternal left trigeminal nerve, and the patient was subsequently diagnosed with NF2. The left image is the axial T1 contrast-enhanced fat-suppressed MRI of a 9-year-old, and it reveals small enhancing vestibular schwannomas in the internal auditory canal and cerebellopontine angles bilaterally. An enhancing mass is also demonstrated in the right trigeminal cistern and found to be a trigeminal schwannoma. The right image is the axial T2-weighted fat-suppressed MRI in the same patient, and it shows the expansion and T2 hypointense signal in the right trigeminal cistern. The internal auditory canal / cerebellopontine angle masses are not well appreciated here. This child was asymptomatic with these lesions. Left is the axial T1 weighted contrast-enhanced MRI of a 70-year-old woman with the neurofibromatosis 2, and it shows the extensive meningiomatosis with dural-based masses in the posterior fossa. There's a small enhancing mass in the left internal auditory canal or cerebellopontine angle, and a tiny, almost imperceptible one at the fundus of the right internal auditory canal. The right image is the coronal T1 contrast-enhanced MRI, and it shows the dural-based meningiomas in the posterior fossa and along the forks and convexities. In this patient, the meningiomatosis predominates over the schwannomas. So the left is the sagittal T2-weighted fat-suppressed MRI of the brain and the upper cervical spine, and it shows the blistering. It shows blistering of the planum sphenoidale, an extra-axial mass in front of the medulla at the foramen magnum, and an enlarged hyperintense cervical spinal cord. The right is the sagittal T1-weighted contrast-enhanced MRI in the same patient, and it shows multiple enhancing meningiomas and enhancing ependymoma of the upper cervical cord. A swan neck deformity is noted in the upper neck from prior multi-level laminectomies. So, starting with the imaging descriptions of the von Hippel-Lindau syndrome. So, now we will discuss the von Hippel-Lindau syndrome cases. Left is the sagittal graphic, and it shows 2 hemangioblastomas in von Hippel-Lindau. In this patient, the spinal cord tumor has an associated cyst, and it would cause myelopathy. The small cerebellar hemangioblastoma would be asymptomatic. On the right is the abdominal von Hippel-Lindau syndrome lesions, and it includes bilateral renal cysts, carcinomas, and pancreatic cysts, and adrenal pheochromocytoma. Left is the sagittal T1 contrast-enhanced fat-suppressed MRI in a patient with the VHL, and it shows multiple cerebellar spinal hemangioblastomas. Right is the coronal T1 contrast-enhanced fat-suppressed MRI in an asymptomatic 26-year-old male with pancreatic cysts, and a family history of VHL shows 2 solid and 1 cystic hemangioblastoma with a mural nodule. So left is the axial graphic, which depicts an endolymphatic sac tumor in a patient with von Hippel-Lindau syndrome. The lesion is a lytic vascular hemorrhagic mass that lies between the internal auditory canal and the sigmoid sinus. Note the tendency to fistulize the inner ear. Right is the axial non-enhanced CT scan in a 51-year-old female with known VHL and sensory neural hearing loss. And it shows a classic feature of VHL, a hyperdense V-shaped hemorrhagic retinal detachment, which is caused by an underlying retinal hemangioblastoma or angioma. Left is the temporal bone CT scan in the same patient, and it shows a lytic infiltrative lesion along the left posterior petrous temporal bone. Note the preserved spicules of bone within this lesion. Location and appearance is quite characteristic for endolymphatic sac tumor. Right is the axial T1 weighted MRI in the same patient, and it shows that the lesion is mixed, iso, and hyperintense relative to the brain. Left is the T2 weighted MRI in the same patient, and it shows that the lesion is heterogeneously hyperintense. Note the hyperintensity in the left vitreous body relative to the normal right globe. Right is the T1 contrast-enhanced fat-suppressed MRI in the same patient, and it shows that the lesion is enhancing intensely but heterogeneously. The retinal hemorrhage is hyperintense on T1. Starting with the cases of tuberous sclerosis, the left image is the axial graphic of the typical brain involvement in tuberous sclerosis complex, and it shows a giant cell astrocytoma in the left foramen of Monro, subependymal nodules, radial migration lines, and cortical/subcortical tubers. Right is the axial FLAIR surveillance scan in a 14-year-old boy with known tuberous sclerosis complex, and it shows a well-demarcated lobulated mass in the left frontal horn, which is a subependymal giant cell astrocytoma. Note multiple expanded gyri with poor gray-white differentiation, that is tubers, and the subcortical white matter hyperintensities. Left is the axial T1 weighted MRI with magnetization transfer in a 13-month-old, and it shows classic findings of tuberous sclerosis, multiple cortical subcortical tubers, and white matter radial migration lines. These lesions are well demonstrated as the signal from normal white matter is suppressed by the empty pulse. Right is the axial T2 weighted MRI, and it demonstrates tubers as T2 hyperintense lesions beneath the expanded clubbed gyri. The white matter radial migration lines are not well appreciated here. Left is the axial T1 weighted MRI in a 13-day-old child, and it nicely demonstrates the multiple T1 bright subcortical tubers, the white matter radial migration lines, and a hyperintense subependymal nodule. The unaffected, unmyelinated white matter is hypointense. Right is the axial T2 weighted MRI in the same patient at 1 year of age, and it shows the T2 hypointense subependymal nodule and multiple T2 bright tubers. Some abnormalities evident on the prior scan are not appreciated here, and some tubers not previously evident are now demonstrated. Left is the axial T2 weighted MRI in a 1-month-old, and it shows multiple T2 hypointense subependymal nodules, which are seen to be originating from the walls of the lateral ventricles. The cortex of the right frontal lobe is thickened and probably diffusely dysplastic. The right image is the axial non-enhanced CT scan of a different patient, and it demonstrates a calcified subependymal nodule along the anterior margin of the atrium of the left lateral ventricle. A hypodense, probably cystic tuber is appreciated in the inferior left frontal lobe. Left is the axial FLAIR MRI, and it shows multiple ill-defined hyperintense bands which are seen to be extending radially from the cortex to the lateral ventricle, and this is a 6-year-old child. Right is the axial T1 weighted MRI with magnetization transfer in the same patient, and it demonstrates multiple T1 bright lesions, pathognomonic for subcortical tubers, and radial migration lines. The diagnosis of tuberous sclerosis is much more easily and confidently made with the T1 with magnetization transfer images than with the FLAIR images.